Good morning, everyone. First of all, let me thank the Total Health team for the kind invitation. It's actually a pleasure and honor to be here. And thank you all of you for being here on Sunday morning. Thanks for taking the time. Although actually seeing how nice the hotel, I don't feel too sorry for you. But no, nonetheless, thank you for being here. So my job today actually was talking about colorectal cancer and anal cancer, and basically focus on what happened last month in GI ASCO. But that's really hard because last year, 2022, and I think you heard Dr. Simobora fantastic presentation. Like 2022 was very, very exciting year for us in the world of GI cancer. So if you allow me, I will go ahead and touch up a little bit on ASCO GI 2023. But it's very important also to cover what happened last year because I think it's very important. So I'm gonna split the talk in two sections. One, a clinical case, and then once we finish the clinical case, I will go ahead and just go over some of the data and the key presentation. And before I this is my disclosures. Before I start the case, I just want to warn you, next is lunch. I know how clinicians do, so there is many ways to treat cancer. And it depends on how much you want to spend on the case, there is less time you're going to spend on lunch. So just keep that in mind. And I'm happy to stay here as long as one. But this is actually a real case I had in my clinic, but it was a couple of years ago. So 42 years old male patient, he initially started with abdominal pain, weakness, fatigue, and then started to have assurance of breast on exertion. He went to see his family doctor, and I'm actually surprised that he had a family doctor, but he went to see his family doctor and was found to have iron deficiency anemia. So his doctor did a good job and started working him up. Unfortunately, when he had a colonoscopy, he had large irregular mass in transverse colon, wink, wink. And biopsy showed body differentiated adenocarcinoma. And then he had a scan, as you see here, showed the liver lesion, and then this is a mass. Just take my word for it. This is the mass in the transverse colon. So then he came to see a medical oncologist, and few questions, and we'll get to the answer in a minute. But when you see that patient, I was curious. What do you test? We just heard that a very important message that few things we should actually test up front. So what you test for and how you test it. And then how long that takes, because obviously, especially for younger people, if you're seeing those patients, you want to be treated yesterday, not like a week or two. And also any other new test, this metastatic disease, so any other new test. Now everyone come to my clinic also asking for circulating DNA. So what do you do? So, I mean, you can feel free to shout the answer. So what is the marker? What do you test or not test? And if you test, what is the marker? Like, anyone? Okay.
You're not going to do a colectomy, so why not biopsy the liver and do all the
That's the growth. So like surgical resection is one of the things, but he had the biopsy already from the colon. So in terms of biomarker, I think, and actually I would argue this should be a standard of care, and if you see anyone in your clinic, you should send at least some of those, or not most of them. So you should test for KRAS, RAS, and I would argue BRAF as well. And as you just heard, IHC or PCR next-gen for MSI status, that's critical now for all patients. I can't agree with my colleague more. It's very important. And now you can argue even that you should test for HER2. I don't think a standard of care yet, but maybe. But for sure, you need KRAS, RAS, and MSI high status. And in our center, we actually use, if we don't do next-gen, we use BRAF and HER2. Okay, so the testing came back showing he happened to have RAS, BRAF, wild type, and like majority of the colorectal cancer, his MSS, but his tumor also was HER2 amplified. So what is the initial option would you consider? Fulfoxyl FOLFIRI plus BEV, Fulfox plus anti-EGFR therapy, Fulfoxiri plus BEV, or chemo plus anti-HER2 therapy, or others. Just for the sake of the time, because some of those answers, a couple of them could be right, actually. I tell you what we did. I personally started him on Fulfoxyl plus BEV, and he stayed for that treatment for about 4 months. He actually had disease response. And then at 6 months, had a stable disease, but started to have some neuropathy. So we took away the oxaliplatin and kept him in maintenance, 5-FU and BEV. And then almost like a year later, in January 2021, unfortunately, he started to have more liver disease. And after several months of therapy. So what would you do next? So his second line now, he had Fulfox plus BEV in the first line, and now progressing on therapy. So what I did, and I understand, again, there is multiple right answer here you can use, actually, but what I did, I gave him FOLFIRI anti-EGFR therapy. The reason I give that, because although it's appropriate to continue BEV, I just was about the volume in the liver, and I needed to feel like I'm getting better control and response to his liver disease. But if someone used BEV instead of anti-EGFR, I think it's still appropriate. So basically, I stayed on this for another year, and then coming back with, unfortunately, disease progression. And this is made up because there is a new data just came out recently and then got FDA approval. So I think that will be the correct answer now. But I want to remind you that his tumor was HER2 amplified, and now he's a refractory setting. So I think, again, there is a couple right options here. But if I seeing this patient today, that's what I would do. I would give him anti-HER2 therapy because he falls in that setting. Just raise your question. Would you, and if you, before that, would you biopsy this patient and test for markers again or test for next gen? Just raise your question. I'm sorry, raise your hand. Okay, so you would do another biopsy. Okay, I think that's reasonable, and especially for people who has anti-EGFR, and I don't want to go into the rationale behind that, but I think it is not unreasonable to do that, but I would say most people wouldn't do it routinely, but nonetheless, if you didn't test, make sure you recorded the molecular marker somewhere you can access 2 years later. All right, so this concluded. You guys did very good. I think you're looking forward for lunch. But this concludes the case. But let me just walk you through the journey. I want to go over the history of colorectal cancer a little bit and then just share with you some of the new data. Some of us, when we were like early of our career or back in medical school, we only had one drug to treat colorectal cancer patient. We had 5-FU, fluorouracil. And back then, the survival, as you see, was about 6 months. So a patient comes with metastatic colorectal cancer, you had only one drug to use it, and their survival for about 6 months or so. We're doing very, very bad. A few years ago, I think now 6, or if I can do the math right, when Alan Van Ook presented the result of 804 study in ASCO, actually showed that median overall survival for patients with metastatic colorectal cancer now is almost 3 years. So went from 5-6 months to 3-year average survival. So big improvement, but I don't think it's enough. In my opinion, I think this happened because of 2 major things we witness over the year. One, we have more drugs. All of us know the more therapeutic option you have for your patient, the better patient will do. Like you do this and then you progress, you give them the next one and the next one, next one. That's actually increased survival. It's very obvious now, very obvious here, as you see in the slide, and I'm sure many of you saw it before. The more therapeutic options, the better survival. And actually should be more update here. But I think also over the year, we start to realize how to use those drugs much better, how to sequence them, how to combine them, which one we use with each other. And I think our ability to do that also improved the outcome. So now we start learn how to do this, I think, in a better way. Back to what I was mentioning about ASCO GI, that a few weeks ago, we were very excited to see new data presented, and I think one of the highlights of 2023 ASCO GI was a sunlight study. So this was presented in the oral colorectal session in Saturday by Dr. Tebrano from Spain. And basically what they did, they asked the question, if adding BEV to TAS-102 will result in improvement in survival. So this study was global study, was randomized phase 3, obviously. The standard of arm, which is very, very interesting, the standard of arm in this case was, okay. So standard of arm was TAS-102, and this was a refractory patient. And I just want to draw your attention that none of the refractory setting used active compound before. The course and other trial was only compared to placebo. So this one was an active standard of arm, which was TAS-102 alone. But the experimental arm was TAS-102 plus PIV. And the regular schedule for TAS, the regular schedule for BEV, and the primary endpoint was overall survival, and it actually was met. So OS for a patient who got TAS-102 plus BEV, they actually had median overall survival of 10.8 months, again, in the refractory settings. Those like people who had FOLFOX, FOLFIRI, BEV, and anti-EGFR if they had RAS wild tumor. And the standard of arm TAS alone had 7.5 months. So I think this was a very important study to be, for all of us to be aware of. Hazard ratio was 0.61, meaning about almost 40 or exactly 39% reduction in the risk of death when you do this, when you treat patient with TAS plus PIV. This was, I think, it was a very important study, and we're really glad to see such a result. And this goes back to my point. There's now more options that we can use to treat our patient in the refractory setting. PFS also was positive, as you see here, 5.6 versus 2.4. I anticipate at some point that might be a new standard of care for our patient. But let me go back a little bit and just talk about the bigger picture. So when we see our patient in the clinic with metastatic colorectal cancer, it's really many factors come together to say, okay, how we should treat that patient, how we should offer him or her whatever kind of treatment we want to do. Sometimes patient characteristic will play a role, age will do, comorbidities, performance status, prior treatment. We also partner with our surgical colleague in terms of surgical resectability, as we mentioned, like maybe you can take the tumor in the liver and primary location, so on and so forth, toxicity. But more and more now in 2022 and 2023, we actually look very closely at tumor marker. We look at KRAS, BRAF, HER2, MSI high, TMB, NTRK, and many other. And in fact, it's very obvious now, we actually witnessing paradigm shift from one size fits all, that everyone get FOLFOX or FOLFIRI or just chemotherapy, to a tailor-made therapy for metastatic colorectal cancer. And I have to say, our vision it changed. Colorectal cancer not anymore one disease or one cancer. It's actually very diverse and heterogeneous group of patients. I tell my patient colorectal cancer is the family name, and each one of patient with colorectal cancer has or have his own or her own unique characteristic. And I would say, and I'm borrowing this from one of my mentor, Terry Andrea from France, who actually led a lot of the immune therapy work, that the sunrise is rising on colorectal cancer. Because we actually now, especially for patients with MSI high tumor, we can actually have a chance of curing them and making them cancer-free. But the story started back a few years ago, which is kind of not too far away, embarrassing. When we start to realize actually right-sided tumor is different from left-sided tumor. So we started to see, okay, like right is different from left, which was very, very interesting finding to see. And in a way, it was embarrassing that it took us that long to find. And I have to give the investigator too much credit, really, because they did a lot of work, and they showed us right-sided tumor has worse biology, left-sided tumor have better biology. But not that only. When you treat them with different drugs, the right drug actually get a huge difference in survival. You can see here 12 months versus almost 37, 38 months. That's a huge, huge difference in outcome. You talk about the same exact disease. But we learned that this not the same exact disease, as I mentioned, is really different. But one of the criticism, one of the issue with that 804 is that what a retrospective study. So this was not meant actually to look at that question, tumor location. This was a retrospective, although it was very interesting finding. And our Japanese colleague actually took this and did a prospective study. So that was the paradigm study. This was presented last year in ASCO plenary session, so it was very, very important. And I think it was published in New England, if I recall correctly. I don't recall when, but it was published it was presented in plenary session in ASCO 2022. And very much they asked that question. They asked, okay, if you have colorectal cancer tumor, what do you do better when you add anti-EGFR or BEV? And this was a randomized phase 3 study. It was multi-center. And I think it had about 800 patients were randomized to get FOLFOX plus panitumumab or FOLFOX plus BEV. The primary endpoint was OS in patient with left-sided tumor. And I just wanted to highlight this was kind of already in progress a little bit while the data was coming from the 804. So that's why they also included all patients. But that was primary endpoint was OS in left-sided tumor. Secondary endpoint was OS in all patients if the primary endpoint was met. So meaning, if they were able to see difference in survival for patients who had left-sided tumor, the secondary endpoint was OS in all population. And sure enough, the study was positive, and turned out that patients who have left-sided tumor, they did better when we treated them with chemo plus panitumumab compared to chemo plus BEV. Median OS was 34 months in the chemo plus BEV compared to 37 months, 0.9 for the chemo plus panitumumab. This was the left-sided tumor. And then they went back and looked at all patients. I think I don't have that slide here, but they went back and looked at all patients, and actually it still was positive, so even for all population. Our group actually looked back around that time in 2017 also, why is he different? Why is he respond different? And it was very clear to us when we looked at tumor sample from colorectal cancer that they actually don't carry the same genetic features. We start to realize it's truly on the molecular side that right-sided tumor, they are different from left-sided tumor. But what was very unique, it is not like black and white. It is not like things get turned off or on once you cross the other side. Was actually more of a continuum of molecular alteration from the right to the left. What I mean, like BRAF mutation is more frequently seen on the right side tumor. But yes, it still can be seen on the left side tumor. It is not as frequent, as common as right side, but you still can see it. Same thing for MSI high. You can see that. The other way around is true. Like HER2 amplification is actually more seen in left-sided tumor. Still, you can see it on the right-sided tumor, but not as frequently as left-sided tumor. So as I said, it's just continuum of a change. It doesn't go from black and white suddenly. And obviously, the reason that's important because it can affect treatment. So we start to feel like our lung cancer colleagues that we start to realize actually colorectal cancer, it is not just tumor location is important, it's also the molecular makeup. Like we start to divide that pie in subgroup population. We have now the MSI high, and really they should be treated totally different. We have BRAF mutant tumor that also have some kind of treatment. We have HER2-amplified tumor, and so on and so on. KRAS is a huge area of interest now. I'm sure you heard about KRAS G12C and how we target this. So like we're really dividing this big tumor to subset of different tumor. And sure enough, we have now FDA-approved therapeutic option based on the molecular marker. So as you heard from the very elegant presentation by Dr. Christina Kumbor, that MSI high now has an approval based on the checkmate Keynote 177. We have in the second line and beyond BRAF target treatment. We have HER2 in the refractory setting, and so on and so forth. And you just heard this presentation, but now in patients who had MSI high tumor colorectal cancer, because of that study, the pembro is approved for first-line treatment. And I just want to also draw your attention to a couple things. This is a first-line metastatic patient. PFS is 16.5 months. We did not see this before. People who actually treat colorectal cancer did not see PFS of 16.5 months before, even with triplet regimen chemotherapy. It didn't reach 16 months. So this, when we saw that data, was fascinating to see how powerful those drugs are. And also, I copy, obviously, what you just mentioned about, like, not all MSI high tumor created equal, and not all MSI high tumor actually respond to checkpoint inhibitor, because you can see in the first 6 months, there are some differences, and chemo actually did better. And this is a huge area of research now, people looking at who are those patients and if we can use more biomarker to find those. But let me switch gear a little bit about another very important topic, which is BRAF-mutated colorectal cancer. So initially when we also were in the beginning of, at least in my career, my understanding of BRAF was this is a bad thing to have. So patients who have BRAF mutation usually do worse. Like their tumor biology is bad. And we'll start to see that in several trials. One of the adjuvant trial showed that actually patients with BRAF mutation tend to relapse further, like more. And also from the metastatic trial, we were able to see like the red curve in the bottom, those the BRAF mutated patient tumor that usually have a worse survival, worse progression-free survival. So it was very obvious to us that BRAF mutation has bad biology. And all of us were not sure what to do about it. And then all of us in the GI community, we got very excited when we start to hear about melanoma and BRAF inhibitor melanoma. Because I remember my colleagues in doing melanoma, they just give the BRAF inhibitor to patients with BRAF mutant melanoma, and they see fascinating response. Almost 78 response rate was seen. And said, okay, that same mutation, the same drug, let's do this in colorectal cancer. So when we did it in colorectal cancer, it was very, very frustrating because it turned out that we don't see that response. 5% response rate when you use BRAF inhibitor for BRAF-mutated CRC. And we started to learn a very important lesson. It is the same mutation, the same drug, but yet Oncogene mutation doesn't imply oncogene dependence. The tumor matter, tumor location matter, tumor site matter. You have to put this in context of which tumor or disease type we're talking about. And then the reason we start, so, and actually I think most of this work was led by the guys, our colleague Anderson, but they went back and tried to understand, so why that happened? Why BRAF-mutant CRC did not respond as well to single-agent BRAF inhibitor? And we start to understand that because the feedback activation of EGFR in BRAF-mutant CRC, which kind of like bypass what you're already blocking. So the feedback may overcome targeting, your inhibition, and the idea was, okay, what about to try to do dual blockade? From that concept came, from that finding came the concept of targeting BRAF and targeting EGFR. I always explain to my patients this way: if you are in London, and I usually use my phone because I can't go anywhere without it, but if you want to use a subway in London, and the green or whatever, or the red subway is blocked, you always can go to wherever you want to go some other way. You can take an alternative pathway to get to your end goal. The same exact thing. If you're blocking one node or one pathway, you're not going to achieve what you're trying to do. This was actually the hypothesis beyond what we know known as now the Beacon study. This was, again, a phase 3 global study, looked at patients who had progression at least on one prior therapy, so it was like a second line and beyond. Randomized them to one, either to get the chemo, which is the standard of care arm plus cetuximab, or to get BRAF inhibitor plus anti-EGFR inhibitor, the middle arm, or to get the triplet MEK inhibitor plus BRAF inhibitor plus EGFR inhibitor. The reason they used the triplet because there was like translational data showing that also MEK inhibition might be helpful. But what turned out that at the end, after everything was done, that in fact it seems that the doublet was as effective as the triplet, and the doublet was more effective than the chemotherapy. So those BRAF mutant patients, when they get encorafenib plus cetuximab, they did actually better compared to chemotherapy. So 9.3 months compared to 5.9 months. And because of that, actually, the regimen was approved. I just want to highlight something here. We have no chemotherapy in this arm. The encorafenib cetuximab, that's a chemo-free regimen. So you just heard about checkpoint inhibitor. It's a chemo-free regimen. You have another regimen in second line and beyond is chemo-free, that's more effective than actually chemotherapy. Because of that, now there is ongoing national phase 3 trials called the Breakwater study, asking very much a similar question, but in the first line. So this was second and beyond. This one, the Breakwater, is the first line study, comparing the chemo plus encorafenib cetuximab compared to encorafenib cetuximab. All right, so let me switch gear now to one of the other very important markers in CRC, which is HER2 amplification. And the reason that's important because there is belief there, I'm not sure how strong is this, but when you talk to people who understand the HER2 very well, they actually believe that tumors that has HER2 amplification tend to be resistant to anti-EGFR therapy. And obviously, the second important reason is that when you have HER2 amplification, that just opens the door to more therapeutic option we have for our patient. This was already proven and established we'll start with Hercules study by our Italian colleagues, and then the My Pathway, which showed response rate about 32%. Those patients had a refractory disease, so like was heavily pretreated. Disease control was 44%. And all of us heard about the Destiny CRC01 a couple of years in ASCO, and now it's published in Lancet. Again, showing PFS of 6.9 months, and OS was not reached, at least at that time. I think there was an update a year ago. But what is important here is not just the PFS or OS. Look at the left side, that you can see the response in refractory patient, refractory tumor, is very long lasting. This is spider blood or spaghetti blood. You see it is not just like in the bottom half, it's actually a very, very long lasting response, which is fascinating. But the most recent data actually we have now is a Montieri study, and this slide is a courtesy of my colleague, Dr. Strickler, who was kind enough to send it to me. He presented that in ESMO GI last year in Barcelona. Very much what they did, they used ticatinib plus trastuzumab in patients who have HER2-amplified in the refractory setting. And again, you can see median OS, median PFS is 8.2 months, and the median OS 24.1 months. This was like a single arm, it's true, but when you talk about 24 months median survival in a refractory setting of heavily pretreated CRC patient, that's fascinating. This was very exciting for us. Because of that, actually, the drug just got approved, that combo just got approved by FDA last month in January, actually during ASCO GI meeting. So I hope I was able to convince you today that we no longer look at colorectal cancer as one disease. We're actually redefining, in an era now of redefining colorectal cancer by tumor biology. As I mentioned before, MSI high, BRAF, HER2, KRAS, and so on and so forth. That's very, very important things to do. This is just a list. It's a very exciting time for us to win GI cancer now, because this is just a list like goes back 2 years ago. 2020, we had an approval for first-line treatment for MSI high patient with Pembro, and Corafenib cetuximab was approved shortly at the same time for second line and beyond, patient with BRAF mutation. And I mentioned ticatinib plus trastuzumab just got approved like almost a month ago for HER2-amplified tumor. And we know also in the refractory setting, there is a checkpoint inhibitor. So it's more evident than ever that all of us trying now to, and we should strive to choose the right patient with the right target for the right treatment. And I think by doing that, we'll actually improve survival and minimize toxicity. And I'm sure every one of you, when you see your patients at clinics, they ask, regardless what stage they have, how can I get off my cancer? How can I get rid of my cancer? So they're asking for the cure. I think this is an obligation on all of us. So really, if we focus on the cure, we have to, all of us to come together and work with each other, and we'll go a full circle from like the molecular discovery, translational research, drug development, clinical research, clinical trial. Please think about it, especially for patients who have disparity and barrier. And then we have to share data together. And then some patient their tumor not gonna respond to the treatment. We have to go back to the lab and start to understand why those patients did not, their tumor did not respond to that treatment that we thought it should respond. By doing that, maybe one day we can actually get to the focus of our journey to be able to cure our patient. Thank you very much.
Thank you. Any questions?
What do you think about the case you presented? You know, you brought up the idea of using the biopsy, but what about just using ctDNA to follow that patient over time and seeing the evolution, clonal evolution of the tumor to target your therapeutic choices?
I think that's an excellent question and actually very important, because circulating tumor DNA is very, very unique technology and very exciting technology we have. And it's start to help us in the adjuvant setting, and I'm sure it will help us also in the metastatic setting. I have to say, I think the technology is moving faster than the science. So we have the test we can order, but sometimes we don't know what does that mean. And also it translates to it's harder to make a treatment decision based on a lot of those results. So we just have to be careful interpreting those results. I don't think we have the data yet, but I have to tell you, we have actually, it's an international study here in Canada, and we have it in our center. It's run by the NSABP Foundation. They're observing like the cDNA dynamic in patients who even have relapse and oligometastatic disease and what happened. And I think that might help us understanding what does that mean. I know that's not really answering your question, but basically, like the short answer, I don't know. Like we can use it, but I don't know if it's gonna be helpful.
In breast cancer, HER2 is generally a driver mutation, and it's conserved with relapses in metastatic disease. And I've yet to see my first HER2 overexpressed colon cancer, but why wouldn't you move up anti-HER2 therapy earlier, as opposed to late, if it's truly a driver? And maybe it's not, maybe it's a passenger.
I actually think that's a excellent question and timely, because now there is a clinical trial, and I think that's also, I don't know it's international, but at least throughout the United States, looking for targeting HER2 in the frontline setting. It's run by or chaired by John Strickler. It's Montier study. So build on that concept. So they're doing like chemo plus or minus tucatinib and trastuzumab in HER2-amplified colorectal cancer in the frontline setting. And I would encourage you, if you please have those patients, because obviously this is like few, think about that trial or send them to a close by center. I don't know if you guys have it in your, you do? Yeah, because, yeah, it takes time, especially with the pandemic, to open it. But the point, what I was trying to make, like, because we're now moving from this big buy to a small subgroup, we need to help each other to be able to get like those patients actually the right, or what we think is the right treatment for them, and doing the clinical trial and finish it. Like what happened with Keynote 177, the immunotherapy, the Beacon study. Those like not a very, very big population, but when you get them right, you actually do very well.
Thank you. Any other questions? Okay, thank you.
Thank you very much. And I do apologize for going over time, but.
Great. So for our virtual attendees, that wraps up our hybrid conference. So I hope you all enjoyed the weekend, and thank you for all asking your questions. For our in-person audience, we're going to head into some lunch. So you can go to the exhibit room, grab some lunch, and then you can eat in here. Not assigned seating, whatever seat you want to choose. Sit with your colleagues and your friends, and we'll enjoy some lunch.